Are you ready to learn with fun? Brace yourselves for the ultimate test of knowledge in the Cardiac Super League. Witness the clash of giants as 12 formidable teams step into the arena, battling it out for cardiology supremacy. In this exciting collaboration between Wilson's Pharmaceuticals and the Pakistan Cardiac Society, the Cardiac Super League promises intense competition and groundbreaking learning experiences. Stay tuned as the teams showcase their expertise, strategic brilliance, and unwavering determination. Who will emerge as the true champions in cardiology? The main goal of the case-based learning approach is to equip students and healthcare professionals to refine their clinical practice by learning the latest advancements. The Cardiac Super League awaits you, guaranteeing to advance your education. Join us and become part of an incredible journey. Visit our Facebook page or contact us for more information.
Assalamu alaikum everyone. This is 𝐂𝐚𝐫 and once again welcome to Pakistan Cardiac Society's Cardiac Super League powered by Wilson's Pharmaceutical. Today we are live for another exciting match, which is 9th match of the Cardiac Super League, and it is between N.I.C.V.D Kings and MAYO KINGFISHERS. To start formal proceeding of the match, I would request the moderator of today's program, Dr. Ashraf Bilal, who is consultant intervention cardiologist at Karachi Institute of Heart Disease, to start the formal proceeding of this match. Over to Dr. Ashraf Bilal for this match.
Assalamu alaikum. Good afternoon, everybody. Thank you very much, Hamza. As we all know that today is the 9th match of Cardiac Super League. The two teams, I will just shortly introduce them. Currently is N.I.C.V.D King and MAYO KINGFISHER. Today we have with us is Dr. 𝐒𝐴𝐚𝐫. He is a interventional cardiologist at N.I.C.V.D. Along with him, we also have Brigadier Abdul Hamid Sadeti Saab. He is associate professor at AFIC. Sorry if I made any mistake, I will apologize for that. And last but not the least, we have our mentor, our professor, always helped us, Professor Ishaq Saab. He will be performing as an umpire for today's match. I would like to thank for all our panelists and including our umpire, Professor Ishaq Saab. Thank you very much. With this, I will move towards the team. N.I.C.V.D Kingfisher, please, can you just come up and introduce your captain and your team members, please, for today's game? N.I.C.V.D Kings.
Am I audible? Hello.
Yes, yes. Go ahead, please.
This is Dr. Bin Nasir, and I am
please
captain of
speak
N.I.C.V.D
loudly.
Okay, so this is Dr. Bin Nasir, and I am captain of team N.I.C.V.D Kings.
I am Syed Danish, and I am member of N.I.C.V.D Kings.
Please close mic at your.
My name is Dr.
Close the
Samad,
mic.
and I am member of N.I.C.V.D Kings.
Okay.
Assalamu alaikum. I am Dr. Sayyeda Muniba, and I am a member of N.I.C.V.D Kings.
Thank you very much. And with this, I will move towards MAYO KINGFISHERS. Please, Team Kingfisher, introduce your captain and your team members, please.
I am Dr. Muzammil Amin. I am the captain. On my right is Dr. Rashid and Dr. Afzal. On my left is Dr. Taqi.
Thank you very much. Okay, now it's my job just to say that who will call the coin. So we have a digital coin, and today I will give a chance to MAYO KINGFISHER to call the coin. So MAYO KINGFISHER, are you ready to call the coin?
Yes, sir.
Okay, please, Hamza, toss the coin. What do you want, head or tail, Kingfishers? Sorry?
Head.
Head, okay. Please, Hamza, toss the coin. Okay, so you won the toss. Very good, Kingfisher. So it's up to you. Would you like to bat first? It means that you want to answer the questions, or you want to ball first? It means you will gonna ask the questions first.
We will answer the questions.
Okay, so you want to bat first, huh?
Yes.
Laurie always want to bat first, huh? Okay, that's fine. So NICVD Karachi, are you ready to ball?
Yes, we are ready.
Okay. Hamza, please move forward to question number 1, please. Okay, so NICVD Kings, you have to read out the main scenario, and then you have to read out the each questions and their stamps, the subsequent stamps as well. So any one of you can do this.
Okay. So 57-year-old male presents to
Please
the emergency.
close the mic to your
it's
mouth
already
and
now.
speak loudly, please.
Okay, actually, I think there's some issue with the mic. It's already in my almost now. Okay, so
then increase your vocal cord voice, please.
Okay. 57-year-old male represents to the emergency room complaining of chest pain, and his ECG is consistent with ST segment elevations, myocardial infarction, STEMI. Upon arrival to the cardiac catheterization lab, the patient's systolic blood pressure is 85 millimeter of mercury, and his heart rate is 115 beats per minute. An emergent right heart catheter is inserted while the patient is being prepared for the intervention. The cardiac index is 1.7.
Can you please share the screen? Can you share the screen, please?
It's coming up to me, sir. Hamza, please share the screen for everybody. It's coming up for me. I don't know why it's not with Professor Saab.
Sir, kindly pin Cardiac Super League screen.
Sir, you have to pin the Cardiac Super League.
Just double tap on the card.
Sir, double click, please, sir.
Yeah, I am on the iPhone.
Oh, I don't know that. How Hamza, how Dr. Professor Saab can sort it out on iPhone?
So you just have to scroll all the screen and then double tap on Cardiac Super League.
Okay, you have carry on. Okay.
Okay, sir. With your permission, can we move forward?
Yeah, please go ahead.
Oh, okay. NICVD, move forward, please.
The cardiac index is 1.7 liter per minute per meter square, and the pulmonary capillary wedge pressure is 19 millimeter of mercury. And intra-aortic balloon pump is placed. However, BP and cardiac index remain low.
Okay, now Mayo Kingfishers, are you happy with it?
Yes,
Could
sir.
we move?
Questions? Yes.
Yes, Mayo Kingfishers, are you happy with the scenario?
Yes, sir. We are.
Got it?
Yes, sir.
Okay, so move to question number 1, please.
So question number 1 is, which of the following medications have been shown to decrease the risk of death in cardiogenic shock? Option A, dopamine. Option B, epinephrine. Option C, norepinephrine. Option D, midrinone. And option E, vasopressin.
Okay, Mayo Kingfisher, your time starts now. So my suggestion is, I don't want to interrupt much, but my suggestion is take your time, relax, you have enough 90 seconds, and then answer your question. Okay, Kingfishers, 48 seconds left.
Sir, we will go with option C.
Sorry?
Option C, not C.
Okay, option C, norepinephrine, isn't it?
Yes, sir.
Please speak loudly.
Yes, sir. Option C.
Okay, Hamza, please lock option C. Please lock option C. Let's see. Oh, very good. Fantastic. Okay, so first over and 6 runs. Very good. Very good. Your beginning is very good. Okay, NICVD. Move towards question number 2, please.
Okay, so next, question number 2. Question number 2 is, post-procedure, the patient remained in cardiogenic shock with pulmonary edema. Which of the following is the most appropriate pharmacotherapy? Nsitide 0.01 mics per kg per minute, dopamine of 10 mics per kg per minute, nitroprusside of 15 mics per minute, milrinone of 0.5 mics per kg per minute, and dobutamine of 2 mics per kg per minute.
Okay, Kingfishers, your time starts now. Okay, 50 seconds left. Still you have enough time. You can think twice, Kingfisher. Thirty seconds left, Kingfisher.
Then we will go with option D.
Option D.
Yes, sir.
Okay, just when you're going to give an answer, please very clear and loud in your answer. Okay, Hamza, stop here. Make answer D. Make answer D. Okay, locked answer D. Milrinone. Oh. Okay, it's wrong answer. Okay, so just a minute before we move forward, because we don't have, I think, the good mic today. Kingfisher, please, in your answer, please loud and clear. Okay. Once you want to give answer, okay? Okay, it's for you. Thank you. So we'll move towards the next questions. Yes, N.I.C.V.D, please ask the next question.
Question number 3 is during the begins to experience hypotension and bradycardia during the procedure. He is adequately volume resuscitated, and you decided to add dopamine. Which of the following is the appropriate dose? 50 mics per kg bolus followed by 5 mics per kg per minute continuous infusion. Option B is 7.5 mics per kg minute continuous infusion. Option C is 15 mics per kg per minute continuous infusion. Option D is 75 mics per kg bolus followed by 20 mics per kg per minute continuous infusion. And option E is 30 mics per kg per minute continuous infusion.
Okay, Kingfisher, your time starts now. Okay, 50 seconds left, Kingfisher. You guys are doing great. Just 30 seconds left, Kingfisher. Okay, now 20 seconds left, Kingfisher, for you.
We will go with option C.
Okay, Hamza, hold on here. Option C, hold on, Hamza, here. Option C, 15 mics per kg per minute continuous infusion. Okay, locked it, please. Very good, fantastic, fantastic. So you really use your time in a right way. Okay, sir, that's fine. So N.I.C.V.D, please move to question number 4.
Okay, so question number 4 is which of the following is true regarding low dose dopamine? Option A, it results in an increase in mucosal perfusion and a higher pH. Option B is extravasation does not result in tissue stopping. Therefore, administration can safely occur through peripheral IV. Option C, it has been proven to decrease incidence of acute renal failure. Option D, low doses stimulate the dopamine receptors and may resolve oligouria. And option E is low doses can be used.
Sorry, there is a distraction of the voice, please. Just hold on, Hamza. Hold on. Hamza, hold on here. Okay, can you just read out the last option again? I think there was a distraction in the voice. E.
Okay, so the last option E is low doses can be used to prevent contrast-induced nephropathy.
Okay, so your time starts now, Kingfishers.
Option D. Option D. Hello.
ये मुझे लगता है माइक काम कर रहा हमारा.
Hello.
Okay, 50
Sir,
seconds
option D,
left.
can you please read out the option?
Sir, option D. Low dose stimulate the dopamine receptor and may resolve oliguria. Option D. Delta. हमने माइक तो
यार अच्छा मुझे तो आवाज आ रही है बड़ी क्लियरली.
Okay, lock.
Dr. Sir, you are muted.
Okay.
सर
can we move?
हमारी
Can you hear us?
सर आवाज आ रही है?
आपकी आवाज कुछ कट रही थी बीच में. That's fine. It's now okay. Okay, so we'll move towards question number 5, please.
Yes, sir.
So, question number 5 is in a similar patient undergoing emergent left heart catheterization for STEMI develops hypotension and an epinephrine infusion is started. During the case, it is noted that peripheral IV where epinephrine was being administered has infiltrated. Which of the following may be useful in treating the extravasation? Option A, hyaluronidase. Option B, hydrazine. Option C, sodium thiosulfate. Option D, normal sulfate. And option D, fentanyl.
Okay, your time starts now, Kingfishers.
Activation है ना?
Interesting समझ नहीं कुछ क्या रहा है.
एग्जाम पे दिया
Activation हो गई है तो उसको क्या करेंगे?
सही है.
अरे तो ए है.
नहीं है हाइड्रोनाइडेस में देना.
अच्छा फिर ई दे कर ले.
नॉर्मल से लाइन कर निकाल दोनों में से ठीक है. डी या ई में सब देख.
Okay, Kingfishers, 45 seconds left.
ठीक
ठीक है
ये करेंगे.
लेकिन उसको हाइपोटेंशन है पहले.
तो अल्फा ब्लॉकर ने क्या?
हाँ तो ठीक करेगा.
We will go with option E, phentolamine.
Okay, so okay, you still have 20 seconds left. You want to go with option number E?
Yes, sir.
Okay, Hamza, lock option E, please. Lock option E. Okay, very good, very good, very good. Zabardast. Okay, so we'll move towards question number 6 now. N.I.C.V.D, please ask question number 6.
Question number 6 is 6 months later. Now the patient with ischemic cardiomyopathy having LVEF of 20 to 25% undergoes a right heart catheterization for progressive heart failure symptoms and recurrent hospitalization with symptoms of volume overload. During the procedure, she becomes extremely short of breath and urine output decreases despite increasing dose of diuretics. Her right heart catheterization shows a cardiac index of 1.8 liter per minute per meter square and PCWP capillary wedge pressure of 32 mm of mercury. Her heart rate is 35 beats per minute and mean arterial pressure is 65 mmHg. Her repeat basic metabolic panel shows increasing serum from 2.5 to 3. Earlier in the day, which of the following should be initiated? Option A, dobutamine. Option B, dopamine. Option C, esmolol. Option D, valerianol. And option E, norepinephrine.
Dopamine.
Okay, Kingfisher, your time starts now.
Yes.
Inodilator भी है वो.
कभी यूज नहीं किया.
65 fresh
ठीक है.
प्रोटीन वेट बेटर करनी है तो डोपामिन मिलेगा उनमें से.
कंट्रैक्टिलिटी बेहतर करने के साथ वो रीनल भी तो बचाना है. फेलियर में जा रहा है.
कंट्रैक्टिलिटी तो होगी तो रीनल पे फेलियर होगी ना. तो कंट्रैक्टिलिटी नहीं तो डोपामिन में डोबेटा अच्छा मैंने वो डोबेटा में किया.
मीन प्रेशर तो ठीक है ना. मीन आर्टेरियल उसके बाद
मीन आर्टेरियल ठीक होनी चाहिए. ठीक है डोपामिन या मिलेनियन में से एक.
Okay, 40 seconds left, Kingfishers.
लग रहे हैं डोपामिन.
Okay, last 30 seconds left.
चलो फिर डॉक्टर करते हैं. ऑप्शन बी डोपामिन.
Option B, B for beta.
यस सर बीटा.
Okay, Hamza, please lock answer option number B, please.
ये तो गलत है वैसे. Oh yeah.
Oh, okay. No worries. No worries. Okay. So with this, we'll move towards question number 7, I think. Am I right?
Yes, sir.
Okay. Move towards question number 7, please.
Okay, so question number 7 is here the patient is undergoing primary PCI for an anterior STEMI. She has received aspirin, ticagrelor, unfractionated heparin infusion, and nitroglycerin at 20 mics per minute. Her blood pressure is 162/89 millimeter of mercury and heart rate is 75 beats per minute. She continues to have ischemia. Which of the following changes is most appropriate? Option A, decrease nitroglycerin to 10 mics per minute. Option B, increase nitroglycerin to 30 mics per minute. Option C, switch nitroglycerin to sodium nitroprusside. Option D, add metoprolol 5 mg IV every 5 minutes for 3 doses. Option E, add morphine 2 to 4 mg IV doses.
Okay, Kingfisher, your time starts now.
ब्लॉकर तो आउट हो गया. 75 तक रेट है. every 5 minutes की
60 में नहीं देता.
मॉर्फिन की बोले क्यों नहीं देते. पीसीआई हो रही है इसकी. तो नाइट्रेट मैक्सिमम डोज क्या है इसकी.
अच्छा अभी
Okay, Kingfisher, 50 seconds left.
ये कंट्रोल करना है.
ठीक है. इशू
डिलीट करेंगे भी कम होगा.
शी कंटिन्यूज टू हैव इस्कीमिया. ये मतलब है कि उसको चेस्ट पेन है. हाँ दमा.
Okay, last 30 seconds left for you.
इस्कीमिया भी हो रहा है. यार अमेरिका नाइट्रोग्लाइसिन की डोज तब बढ़ाते हैं अगर
20 seconds left.
काम करना तो
बीपी नहीं काम करना काफी. 160.
15 seconds left.
Sir, we will go with option E.
Option E. Okay, Hamza, hold on and lock option E. B. E. Okay. Okay. Sorry for that. Okay. With this, we'll move towards our question number 8. N.I.C.V.D, please speak loudly the question and the relevant, the options as well.
Okay. So question number 8. While primary PCI was being performed on this patient, she developed diffuse vasoconstriction in the target vessel. This was successfully ameliorated with the intracoronary nitroprusside of 400 mics. Subsequently, the patient developed hypertension having a MAP of 52 millimeter of mercury and tachycardia with a heart rate of 106 beats per minute. In addition to IV fluids, which of the following is the best agent to reverse hypertension in this patient? Option A, dobutamine. Option B, dopamine. Option C, epinephrine. Option D, isoproterenol. And option E, phenylephrine.
Okay, Kingfisher, your time starts now.
थल्लेडे वाले दो तो काट दो तो चलो एपिनेफ्रीन भी नहीं क्यों नॉन एपिन देगा अब है ही नहीं है उसका बस नोट रिपोर्ट तक नहीं देगा डोपामाइन विटामिन तो आप लिख लो हार्ट रेट कितना हार्ट रेट भी ज्यादा है एपिनेफ्रीन शॉप में देखते हैं फिनाइलेफ्रीन क्या है ये अल्फा एगोनिस्ट है अल्फा एगोनिस्ट है हाँ लेकिन बीपी को बढ़ाता है वो भी एपिनेफ्रीन क्या है एपिनेफ्रीन टैकीकार्डिया भी तो करेगी तो हम लोग बीपी को भी
40 seconds left, Kingfishers. Last 30 seconds left.
क्या करेंगे कर दें ऐसे जाएं फिर ये कैसा सी पे चले जाओ एफी नहीं टैकीकार्डिया फिर कर दो फिर ई कर दो we will go with
15 seconds left, Kingfisher.
phenylephrine
E. You want to go with option number E?
yes sir
Okay, Hamza, log option E, please. Very good, very good. So now with this, MAYO Kingfisher, you move towards 30 score, and you still have 2 questions left. So, okay, N.I.C.V.D King, ask the second last question, please.
Question number 9 is, previous history reveals the patient had pulmonary arterial hypertension secondary to HIV. Now she presents with onset of severe chest pain. Her ECG reveals new ST segment depression. Her initial blood pressure is 132/88 millimeter of mercury and her heart rate is 93 beats per minute. Caution should be exercised with administration of which of the following? Option A, aspirin 325 milligram chewed or crushed and then swallowed. Option B, enoxaparin of 1 milligram per kg subcutaneously every 12 hourly. Option C, metoprolol 12.5 milligram orally every 12 hourly. Option D, nitroglycerine continuous infusion starting at 10 to 20 mics per minute. Option E, unfractionated heparin 60 units per kg bolus followed by 12 units per kg per hour.
Okay, Kingfishers, your time starts now.
क्योंकि pulmonary hypertension है तो वो ले रहा होगा ना sildenafil
यार गुड यार यही बात है अफसल भाई बिल्कुल सही बात है ये पल्मोनरी हाइपरटेंशन उसको काफी कंट्रा इंडिकेटेड हो जाता है क्या
sildenafil ले रहा होगा ना
ले रहा होगा ये देखा ना अगर इनॉक्साप्रिन में भी है तो अनफ्रैक्शन हेपरिन में मिल सकती है वो तो वैसे ही दोनों आउट हो गए एस्प्रिन और मेटोप्रोलोल तो आपने देना उसको
मेटोप्रोलोल और डी पे है ना तो डी में कॉशन है ना कॉशन ठीक है
डी ऑप्शन है we will go with option D nitroglycerin
Okay, are you sure you still have 40 seconds left?
sir we are sure
Okay, Hamza, please lock option D. Hamza, please lock option D. Very good. With this, Kingfishers, you move to 32. Your score is moved to 36, which is very good. And you have last over to face. So, Karachi King, please deliver your last over.
Okay, so question number 10 is while in CCU, post-procedure, the patient has witnessed cardiac arrest. She had returned of spontaneous rhythm following advanced cardiac life support, including cardiopulmonary resuscitation and defibrillation. At the time of arrival, her blood pressure is 75/40 millimeter of mercury and her heart rate is 55 beats per minute. In the emergency department, she is started on dopamine 15 mics per kg per minute and placed on a mild therapeutic hypothermia protocol. The ECG is consistent with inferior STEMI with second-degree AV block. In the cardiac catheterization lab, an IABP is placed with 2:1 augmentation. The patient remains hypertensive with a systolic blood pressure of less than 90 millimeter of mercury. Which of the following will be most helpful? Option A, switch dopamine to norepinephrine. Option B, administer IV fluid boluses. Option C, change IABP 1:1 augmentation to provide better systolic blood pressure support. Option D, add milrinone to increase in heart rate, cardiac output, and blood pressure. Option E, add IV nitroglycerin to prevent recurrent ischemia.
Okay, Kingfishers, the time starts now.
पहले दूसरा दे अगर इंफीरियर बॉल MI उसकी वजह से आर्मी पावर की वजह से फिर इशू बन रहा इसके उसमें आर्मी पावर की वजह से बीपी नीचे आ रहा है प्रेशर्स का तो कुछ नहीं बताया हुआ ना फ्लूइड देने से आर्मी पावर की वजह से ऊपर चले जाएगा ये बीपी भी अगर 2:1 से 1:1 जाते हैं तो वो भी बीपी बढ़ाता है वैसे मगर ये इंफीरियर वाला MI है मेरे ख्याल से फ्लूइड वाले यहाँ होगा
Sir, we will go with option B.
Option B?
Yes, sir.
Okay, are you sure? You have 40 seconds left.
Sir, sure.
Yeah. Okay, Hamza, they are sure, so please lock option number B. Yes. Very good, very good, very good. You were absolutely sure and rightly sure. Okay, good luck. So I think you got 36 points.
42, sir. Sir, 42.
Sir, 42 है
42 now? Oh, very good.
I hope so.
Okay. So meanwhile, Karachi Kings, you just take N.I.C.V.D Kings, you can just take a little rest. I would like to move towards Brigadier Abdul Hamid Siddiqui Saab. Sir, please, can you just give us a brief your opinion about the game up till now? Over to Professor Abdul Hamid Siddiqui Saab.
Thank you very much for providing me this opportunity. I think the scenario was very good. It was really practical, and the questions were very appropriate with very subtle changes in the answer, which is really required by the fellows to know at which point which drug they have to administer in the case of cardiogenic shock. And it is relevant in our scenario as well, since we don't have very sort of very high end equipment in our setup because of the obvious situation. So we do manipulate or we use these drugs in order to save patient life. So I think very good, excellent scenario and very good answer from the.
Thank you very much,
MAYO Kings.
Brigadier Saab. You have a very nice comment. Hamza, we will be more happy and we're gonna enjoy it more if we can see the Brigadier Saab face as well. We are unable to see him. Anyhow, can you just make it for the next time? Okay. And with this, I will move to Professor Ishaq for his short comment, and then we'll move to the second part of the game. Professor Ishaq.
Thank you, Asher. I think it was very interesting, and as Brigadier Hamid has said, Hamid sir, it was a very practical question, and something I actually felt that I was sitting in the ICU and CCU setting, you see, and I think the answers were very good. The question was very good, and the options were also very good. I mean, the right answer was quite clear and outstanding. So I think on the whole, so far so good, and we have seen very good sportsman spirit on both sides. So I think once the match is over, I'll be able to give some more conclusive remarks. But I think the question was good, and the stems were very, very appropriate to our day-to-day practice. And as Siddiqui Saab has said, that we don't have that kind of sophisticated equipment. We have to rely mostly on these IV infusions of various pharmacological agents. So thank you very much, Asher, for conducting it very nicely. So I think without wasting time, we should move on to the
Yes, sir.
next.
With your valuable comments, now we will move toward the second innings. So, Karachi Kings, are you ready to bat? I mean, N.I.C.V.D Kings, are you ready to bat? Okay. So now it's, I will move towards Mayo Kingfisher. Please start your over number 1. Mayo Kingfisher, please put your scenario and then start your over number 1. Oh my God. Okay. Please read out clearly.
A 68-year-old man present to his new primary care provider or an initial patient visit. His sole active complaint is mild retrosternal chest pressure that he experiences on after significant exertion. The discomfort resolves within minutes of cessation of the provoking activity. The pattern and severity of his symptom has not changed significantly over the past 3 years, as he denies an episode of chest pain at rest, dizziness, syncope, dyspnea, palpitation, or lower extremity edema. He has a history of coronary artery disease requiring PCI with placement of a bare metal stent to the right coronary artery 5 years ago. He was told that his other coronary vessels were mild disease and there were no other lesions suitable for PCI. Other pertinent medical history include hypercholesteremia and long-standing hypertension. His current medication include aspirin 81 mg, metoprolol succinate 25 mg, simvastatin 10 mg, and hydrochlorothiazide 12.5 mg. He is a lifelong non-smoker and does not consume alcohol or use illicit drugs. On examination, the patient is comfortable and in no acute distress. The heart rate is 90 and regular, and on the blood pressure is 155 by 85 millimeter of mercury in the left arm. There are no murmur, rubs, gallops, or clicks on the cardiac auscultation, and the second heart sound is physiologically split. There are no apparent extra heart sounds. The remainder of the physical examination is unremarkable.
Okay, I'll hold you here. Okay, so N.I.C.V.D Kings, are you happy with the scenario and should we move forward?
Yes, we are happy to move forward.
Okay, so just deliver your over now. Okay, this is an ECG. Okay, should we move forward?
Leads.
Yes, Kings.
In this ECG.
Yes, Kings. Should we move forward?
Actually, what I'm trying to say is leads are not mentioned here. What leads are they?
Okay, so you can assume that it's a routine leads, okay?
Okay.
Okay, so we'll move forward now. Please ask your question number 1. Kingfisher, please.
Yes. What is the diagnosis?
What is the diagnosis? Unstable angina, walk-through angina, chronic stable angina, warm-up angina.
Okay, your time starts now.
So, unstable angina after increasing frequency. Unstable angina. 5 years ago.
Okay, now 50 seconds left.
Okay, so the answer is C, chronic stable angina.
Okay, so you want to choose option C?
Yes.
Okay, are you sure you still have 35 seconds left?
Yes, we are sure.
Okay, Hamza, log C, please, log option number C. Okay, very good, very good. Your beginning is very good. Your openers are really good. So with this, we'll move to question number 2. Please, Kingfishers, ask the next question.
What will the next best step in his management? PCI to RCA, intensification of GDMT, treadmill ETT, CT cornea angiography.
Okay, your time starts now.
उन्होंने पता क्या बोली ना उन्होंने बी लगाना है
उठा गए थे
Sir, N.I.C.V.D team are requested to please unmute their mic.
Yeah, please. Yeah, 43 seconds left.
Thank you, sir.
Okay, so are you that one? What?
Yes, 30 seconds left. Kings, please.
Okay, so our answer is B for ball, intensification of guideline directed medical therapy.
Okay, Hamza, hold on the timer and lock option number B, please. Very good, fantastic. Okay, okay. So okay, we'll move towards question number 3.
This non-invasive test is useful in case of if he has left bundle branch block on his ECG, ETT, exercise, MPI, CT cornea angiography, stress debutamine.
ETP तो हटाई देंगे कि यार BMS लगाया तो CT हाँ BMS लगा हाँ और CT as I stress level या stress
stress 5 MPI नहीं हम MPI करते हैं वो वाला फार्माकोलॉजिकल करते हैं उस पेशेंट का जिसको LVP तो LVP वाली जो कैटेगरी है उसमें हम फार्माकोलॉजिकल जाते हैं एक्सरसाइज नहीं कर पाते हैं तो एक्सरसाइज MPI so I think we should go for the stress level exercise MPI दूसरा आता है exercise MPI फार्माकोलॉजिकल तो हमारे पास एम्प्लीट्यूड आ रही है
Okay, now 50 seconds left. Kings.
क्योंकि वो बात है कि तो हम फार्माकोलॉजिकल करवा दें आप एक्सरसाइज करेंगे उसमें फिजियोलॉजिकल रिस्पांस भी देख लोगे कि पेशेंट की कंडीशन क्या है और प्लस आप उसका एमपीआई भी देख लोगे आप किसी चीज नहीं देखेंगे
Okay, 30 seconds left, please.
So the answer is D, stress debutamine.
Okay. Are you sure 20 seconds left still? Should we lock the answer?
Yes, we are sure.
Okay, Hamza, lock the answer D. Stress debutamine. Oh, okay, no worries. You still have a lot of questions available. Okay, Kingfishers, please move towards number 4.
This patient GDMT has been intensified recently, but still his exertional angina is not settled. What to do next? Cornea angiography, CT cornea angiography, stress MPI, stress echo.
Okay, your time starts now. N.I.C.V.D Kings.
3 साल हो गए 3 साल पहले RC हुई थी बाकी वजह से कुछ नहीं था इतने डिजीज नहीं थी BMS से हुई थी और ट्रीटमेंट इंटेंसिफाई कर दिया है तो उसके बावजूद सिम्पटम्स हो रहे हैं तो हाँ अभी इस पेशेंट को हम LPV वाला कंसीडर करेंगे नहीं करेंगे नहीं ठीक है तो
the patient has intensified electrical still
Okay, 50 seconds left. N.I.C.V.D Kings.
What do you think? Will be what?
Okay, final 30 seconds left.
Will be intensified. I think
Okay, 15 seconds left. N.I.C.V.D Kings. 10 seconds left.
Okay. Okay, so the option is A, coronary angiography.
Okay, Hamza, hold on. Hold on, it's only 2 seconds. Okay. Log option number A. Okay, very good. You guys had a narrow escape, huh? Very good. So that's fine. So with this, we will move towards question number 5, I think. If I'm right. Yes. Okay, please go ahead.
Which of the following statements regarding stable coronary artery disease is most accurate? PCI is associated with improved survival compared with optimal medical therapy in patients with stable angina. Ranolazine therapy is associated with a decreased risk of myocardial infarction in patients with stable angina. All patients with abnormal stress test results should be referred for coronary angiography to assess or obstructive epicardial coronary disease. Beta blockers, calcium channel antagonists, and nitrates are considered first-line anti-anginal medications. The elements that constitute the Duke treadmill score include exercise duration, degree of ST segment elevation, and the number of abnormal left ventricular segments seen on myocardial imaging.
Okay. Time starts now.
All patients with abnormal stress. Abnormal stress test जो होती है ना class 1 indication होती है तो कौन जीरा? अगर आपका stress normal आता है इसके अंदर ये class 1 indication के stress से सामने कोई नहीं करा abnormal आता है तो you go for the rapid blood flow. So guidelines में तो ये है कि class 1 indication. Beta blocker test के अंदर कोई जैसे आप first line indication C or D. C or D. D is out. D is out. I think.
Okay, 50 seconds left. Okay, final 30 seconds left.
Okay, so the answer is C. All the patients with abnormal stress test should be referred for the coronary angiography.
Okay, are you sure we should lock it?
Yes, we are sure.
Okay, Hamza, lock option C, please. Oh, okay, no worries. Still, you have 5 questions left. Okay, you still have hooks and pulls and everything in your pocket, which you can do. So now onwards, N.I.C.V.D Kings, you have to start batting like 𝐂𝐚𝐫𝐢𝐚𝐜, huh? Okay, so we'll move with question number 6. You have to elevate your 𝐂𝐚𝐫𝐢𝐚𝐜.
Among patients with class 2 angina and 1 or 2 vessel disease, PCI is indicated for which of the following? To prevent progression of the coronary artery disease, prevention of MI, to elevate asymptomatic ischemia, to improve symptoms, or option E, prevention of death.
Okay, your time starts now. N.I.C.V.D.
Prevention of progression of coronary artery disease with lifetime modifications.
ठीक मेरे ख्याल से हाँ ये है ना ठीक लग रहा है ये ना ताकि
Okay, 50 seconds left. N.I.C.V.D Kings.
One or two, 8 करोड़ class में
Okay, final 30 seconds. Okay, 16 seconds left. 10 seconds left. 5 seconds left.
Okay, so, option B, prevention of MI.
Hold on. Option D. You say D for Delta.
B for balls, prevention of MI.
Okay, Hamza. Please lock answer B. B for ball. Oh. Okay. Good luck. Okay, so I think 𝐂𝐚𝐫 has a backache, huh? Today.
Sir,
it cannot be full.
सर 𝐂𝐚𝐫 ने इंडिया के खिलाफ कोई भी 0 बनाया 12 बॉलों पे.
Hello, तो इसका मतलब we have to come back again to Babar Azam, huh?
Yes, sir.
Okay, that's fine. Anyway, we'll move forward now. People are waiting for us, so ask next question, please.
Side effect of nicotine in stable ischemic heart disease is option A, constipation, option B, hepatic dysfunction, option C, perianal ulcers, and option D, QT prolongation.
Okay, your time starts now, N.I.C.V.D Kings. So, N.I.C.V.D King, you cannot lose the answer, okay? If you lose the answer, you will gonna lose the match from now. So take care, be careful. It's 40 seconds left. If your answer is wrong, you will gonna lose the match. 30 seconds left.
So option D, QT prolongation.
Okay, are you sure you still have 20 seconds? Should we lock option D? Yes, please answer. 16 seconds left. Should I lock?
Let's go for D.
Okay. Hamza, please hold on and lock answer D. Okay, now that's fine, that's fair enough. So we have the result with our hand, but according to the game, we have to complete the game now. So we will have to ask the whole questions. Okay, so bear with us and don't dishearten. You still, whatever the points you will get, this will count in the future as well. Karachi, please. Okay, so I will move towards Mayo Kingfisher. Please ask your next question.
Routine invasive therapy is not better than the medical therapy in moderate to severe risk patient for MACE. This conclusion is validated by COURAGE trial, ACME trial, Berry trial, and ischemia trial.
Your time starts now.
Okay, so the answer is D, ischemia trial.
Sorry?
Answer is D, ischemia trial.
Okay, it's 77. Okay, so you want to pull now, huh? You want to pull every ball now? Are you sure?
Yes.
Okay. Okay, we'll hold option D. Please lock option D. Very good, very good. Why you sent your 𝐂𝐚𝐫 at number 8? I don't know why. Anyway, we'll move with question number 9 too.
Which of the following statements are not true in regard to medical therapy versus PCI for coronary stable angina? Option A, PCI is more effective than medical therapy in reducing CV mortality in patients with coronary stable angina. Option B, PCI is more effective than medical therapy for symptomatic relief of angina. Option C, PCI plus optimal medical therapy in the COURAGE trial was no more effective than optimal medical therapy alone in preventing mortality or myocardial infarction in patients with stable coronary artery disease. And option D, as evidenced by the nuclear sub-study of the 𝐒𝐚𝐫 trial, plus PCI plus optimal medical therapy is more effective than the optimal medical therapy alone in reduction of ischemia in patient with stable coronary artery disease.
Okay, Karachi, your time starts now. N.I.C.V.D Kings, your time starts now.
Which one is not true, na? A is not true. It has more effective than medical therapy. You see, mortality to नहीं होती है.
That's why तो आपके पास senior trial है.
Clear cut हमें लगता है कि true नहीं है. PCI is more effective than medical therapy percent. PCI plus optimal medical therapy in the 𝐶𝐻 trial was more effective than the optimal medical therapy alone. In preventing mortality, no more effective. 𝐶𝐻 standard.
Okay, 45 seconds left. Karachi. Kings रखा है. Okay, 30 seconds left. N.I.C.V.D Kings.
Okay. So the answer is A. PCI more effective than.
Okay. Don't read full stamp. Don't read. Okay, are you sure? Answer A.
Yes, we are sure.
Okay, Hamza, where are you? Hamza, please hold on and lock option number A.
Yes.
Okay, another from 𝐒𝐚𝐫, huh? Okay, well, I don't know who was the captain of the team who sent 𝐒𝐚𝐫 at number 8. Anyway, we'll move to last question. Question number 10. Okay.
For a patient with stable coronary artery disease, which of the following statement is not true about the role of PCI versus coronary artery bypass? Option A, in a patient with 80% lesion of the left anterior descending artery, there is no difference between PCI and 𝐶𝐽 in the rates of long-term cardiovascular death or myocardial infarction. Option B, for most patients, there is no difference between PCI and 𝐶𝐽 in terms of overall mortality. And option C, in a patient with diabetes mellitus and multivessel coronary artery disease, there is a greater reduction in mortality with 𝐶𝐽 over PCI. Option D, in general, PCI has a higher rate of recurrent angina than 𝐶𝐽. And option E, in general, 𝐶𝐽 has a low rate of long-term myocardial infarction than PCI.
Okay, N.I.C.V.D Kings, your time starts now.
B गलत है ना, for question there is no difference. There should be a difference between and travel instruction.
They are talking about the schedule. With 80% lesion of the LAD. So LAD is for capital, na? For capital.
Okay, 50 seconds left. N.I.C.V.D Kings.
80% lesion LAD. For most patients, there is no difference between PCI and 𝐶𝐽 in terms of overall mortality.
Maybe 3 or 4 they are saying for most patients.
We are talking in the context of stable coronary artery disease, and they are saying for most patients.
Okay, last 30 seconds left. Sorry, I have to do my job. I have to interfere, but I don't want to interfere, but I have to do my job. Okay, last 20 seconds left. N.I.C.V.D Kings.
A or B? I think we should go.
10 seconds left. 9, 8, 7.
Okay, so the answer is
yes.
A.
Hold on, Hamza. What
answer is A.
A. Okay. Hamza, okay. Give them a chance and lock answer number A, please. Lock answer A. Oh, bad luck. Okay, so 𝐒𝐚𝐫 is caught at the cover boundary. Okay, no problem, no worries. Thank you very much, guys. So its game is finished, and with this, I have a news that Mayo Kingfishers won the game and they got 42 marks 42 numbers as compared to, I think, 30 number. Please, Amla, show me the number. Okay. So Mayo Kingfishers got 42 score and N.I.C.V.D Kings scored 30. With this, our today's winner is Mayo Kingfishers. Congratulations to you and good luck for your future. Yes, Kingfishers. Okay, now with this, I will move to my dearest friend. We don't along with a long time, but he's really my good friend. I'm going to move towards Professor Hamid from Rawalpindi Institute of Cardiology to get his valuable comment. Hamid, it's over to you, please.
So thank you very much for inviting me on this forum. A very interesting kind of a battle going on between two prestigious institutes. I'm very happy to know the level of knowledge and confidence these young guys have when it comes to study. The things that I'm going to make, number one, I'm very happy with the quality of questions that they have made. It's very important because it's mostly based on our day-on, day-out activities. We need to know the inotropes because when we are in the cath lab or in the emergency department, based on different scenarios, we can have to give different kind of inotropes. One is superficial or better than the other, and the other is inferior to the other. So it's very important for us to know which kind of inotrope would be specific in a specific setting, and that is going to help us a lot in getting better outcomes for the patients. And I was very pleased to know that one of the teams who had that question, they were able to answer quite a few questions in those quite difficult questions, because routinely we prepare such questions only for exams, to be honest. And when it comes to our day-on-day activities, we don't intend to work a lot on them, and we just give them either dobutamine or dopamine. But it's very important for us to know that which medication is helpful in a particular situation, like for example, somebody having a raised wedge pressure or somebody having a rate peripheral resistance and all that. Secondly, chronic stable angina, again, a very important topic, and the guidelines have changed over a period of time. There have been a paradigm shift, you can say. Initially, it was a stenotic response. Every time that we used to see a stenosis in chronic stable angina, we used to stent it. But now, based on the recent guidelines and the recent trials, it's very important for us to be very specific, and the management differ from patient to patient. So we have to put all this knowledge, all this into practice as well. When a patient comes up with a lesion in the LAD or RC and if he is asymptomatic with medical therapy, it's very important for us to pursue on taking medication. And because this is very important in the Western world now, the guidance has changed towards medical therapy very profoundly, and only in certain cases in which there is unstable angina or debilitating angina despite medical therapy, we have to go for medications. Another important and last question that I need to say at this level is very important for us to be aware of the recent trials. If we look at the current exams in American boards and also in CCT, a lot of stress is given on the latest trials, the knowledge, and then their application on the current practice. So I would stress upon these young trainees and graduates to be aware of the recent trials and what the impact of this trial on our current practice, and try to inculcate that into the current practice as well. In short, I'm very happy with the standard of the questions that were on display, the standard of, mashallah, the knowledge on both teams. And obviously, one team has to win and the other has to lose. But when it comes to learning from other mistakes, from your own mistakes, and then you just reflect upon your weak points, and you then become a better doctor as well, both for the patients and from the clinical perspective as well. Again, very thankful to the sponsors for giving me the opportunity to talk on this forum. And I'm very happy to know that these kinds of activities are going on, and this will benefit both these doctors and as well as the patient in the long term. Thank you very much.
Thank you, Professor Hamid. Thank you for your valuable comments. And with this, I will move again to Brigadier Abdul Hamid Siddiqui Saab. Just give your final comments for this game. Brigadier Saab, over to you, please. And this time we are happy to see your face as well. I think your mic is mute, Professor.
Okay, thank you.
Okay.
I think full marks to Mayo team. They answered very well of a very practical but slightly difficult scenario as compared to the one which was posed to the N.I.C.V.D team. I think the answers were according to the latest trial that have been actually published recently. So very good activity, and I think practical scenario, and we should continue this activity. Thank you very much.
Thank you very much, Brigadier Abdul Hamid Siddiqui Saab. And with this, I'm going to move again towards my mentor, Professor Ishaq Saab, for his final comments before we sign off. Professor Ishaq Saab, please, over to you.
Thank you very much, Ashar. Very interesting match today, and very nice comments from my distinguished colleagues, Hamid and both Hamids. Cardiogenic shock is not an uncommon condition, and every person who wants to be a cardiologist should be well versed with the management of cardiogenic shock. And as somebody already pointed out, not every center will have intra-aortic balloon pump, so we need to know pharmacological treatment, how best to revive the patient in the cardiogenic shock. So that's very important. I think the questions were very good. The second scenario, to my mind, was a bit too lengthy. The text, I mean. I wish we could make it a bit more short. The third comment that I would like to make is that we are living in the era of evidence-based medicine. So I think guidelines, guided treatment is the solution. We don't have to think much. We have to remember. Okay, in this situation, this is the drug of choice, and a very interesting development which has taken place is now we are moving towards pharmacological treatment, optimal medical treatment versus intervention in all cases. So we have to be very selective if we want to intervene somebody mechanically, that this patient is only suitable for intervention and not for optimal medical treatment. So I think with this, this is a very good, healthy exercise that we are conducting for the last 9 weeks. And not only that, the fellows learn, at least as I'm concerned, I'm learning a lot. I'm refreshing my knowledge and updating myself. And I think a doctor can manage a patient in the CCU and ICU without mechanical intervention. I think I would endorse such a person to be very effective in our clinical setting. So with this, Ashar, thank you very much for conducting it in a very nice manner. I would like Hamza, the Wilson, to have this internet problem sorted before the start of the match so that we don't lose time. And for the team which has scored less, nothing to be disheartened. You have to just carry on with your studies, and this has to be very sportsman sort of thing that you should learn. Somebody has to score more, and so eventually when we have the final score, then we'll have all these numbers in front of us, and we'll see who is on the top. But please keep it up. And the other thing is that you are given 90 seconds. So please don't jump onto the conclusion quickly. Utilize your time, 90 seconds, and you should at least take 60 seconds before you make an answer. Sometime in a rush, you can make a wrong answer. So with this, I would like to thank Messrs. Wilson Pharmaceuticals for having me, and my good regards to Brigadier Siddiqui and Hamid Sharif. Nice to see them. And Ashar, I'm very glad that you're doing well at KHD. I remember you came a few years ago, and it was me who thought that we should have you with us in our team. So well done. And I think it's raining torrentially here. So I'm going to visit some friend now. Thank you very much. And Allah Hafiz to everybody.
Okay, thank you very much. With this, I will thank for all my panel experts, including Professor Hamid from RIC and Brigadier Professor Abdul Hamid from AFIC and Professor Ishaq and both team, MAYO Kingfishers and N.I.C.V.D Kings. I think they already left. Hamza, please, we sign off from now. And thank you very much, everybody. And we'll see you next week, or maybe week after that. I think it is Muharram next week, so probably week after that. Thank you very much. Okay,
Thank
Hamza,
you.
please sign off, Hamza.
Thank you, everyone.
Over to you.
Thank you very much, sir. I'm extremely thankful to all the expert panelists who are with us for this match. Dr. Mohammad Ishaq Saab, Brigadier Abdul Hamid Siddiqui Saab, and Dr. Hamid Sharif Saab. And without, and Dr. and last but not the least, Dr. Ashraf Bilal. So, congratulations to Mayo Kingfishers. And hopefully we will be sharing the results of this Group A very soon on Monday, inshallah. And then we will it will be decided that who's both two teams are qualified for the knockout stages. And this is the final match. This was the final match of Group A, and we have concluded Group A all matches. And on Monday we will disclose who two teams are qualified, because at the moment all the three teams have the same points, and we have to decide on the basis of run rate that who are the two teams who are qualified for the knockout stages. So with this, I'm again extremely thankful to all the panelists, and Allah Hafiz and take care.